Thank you, Panagiotis. Just give me a minute. Καλησπέρα σε όλους. Δεν ξέρω αν με ακούτε. Παναγιώτη, μπορούμε να ξεκινήσουμε?
Ναι, έχει
Ωραία, ωραία. Καλησπέρα σε όλους. Έχουμε μαζί μας τον καθηγητή Ρίμελε από την Λιόν της Γαλλίας. Θα τον συστήσω σε ένα λεπτό. Ό,τι χρειάζεστε από ερωτήσεις και τα λοιπά θα τα ανεβάσετε στο chat και όταν τελειώσει η κυρία Λαβρεντίεβα θα κάνει το coordination όσον αφορά τις ερωτήσεις και τα λοιπά. Και ό,τι άλλο θέλετε να ρωτήσετε, Παναγιώτη, μπορούν να ανεβάζουν χέρι και να τους ανοίγεις.
Ακριβώς, όποιος
Πάμε μόνο με
θα
chat.
το χέρι
Ναι.
και να του ανοίξουμε το μικρόφωνο.
Ωραία, τέλει. Λοιπόν, if you allow me to introduce Professor Rimele, he's an anesthesiologist and intensive care specialist at the Edouard Herriot Hospital in Lyon, France, and he just informed us from September he's gonna move to Nice to get a head position at the hospital in Nice, France. He's an intensivist and anesthesiologist. He has done his training mostly in France. He's done 2.5-year postdoc in the States. And his main interest is in kidney injury, renal replacement therapy, and simulation in healthcare. And from what I understand, he's the director of the Simulation Center at the Lyon University. He's done a lot of work, more than 200 publications in peer-reviewed journals. And he is going to talk to us how to provide renal replacement therapy in the ICU in the year 2025. Professor Rimele, the floor is yours.
Well, thank you very much. I would like to thank you, Atina. Thank you, Maria, for inviting me to this webinar. I would like to say hello to all my Greek friends and welcome to these colleagues from Greece. It's a pleasure for me to give this lecture about renal replacement therapy in the ICU. I will speak about 40-45 minutes, and then we will have 10-15 minutes to discuss. If you can keep your questions for the end, that would be good. These are my conflicts of interest. I am working with these companies these companies are involved in the field of AKI and renal replacement therapy in the ICU. This is the outline I'm going to follow during the next 45 minutes. A little bit of epidemiology, 1 or 2 slides only, and then I'm going to talk about all the aspects of renal replacement therapy in the ICU. Dialysis catheters, very important, the timing of renal replacement therapy, the dose of renal replacement therapy, the modality, and we're going to end with citrate anticoagulation. So in terms of, as for the introduction, I will have 2 slides about epidemiology and actually 2 numbers that are very important to have in mind, 75% and 10%. Can you imagine what these percentages are? Well, these percentages are the number of ICU patients with AKI. In the ICU, if you carefully look at the number of people with AKI in your unit, you will find that 75% of your patients, they have AKI. A lot of them have AKI stage 1 of the KDIGO classification, but you will have also AKI stage 2 and AKI stage 3. And if you look at the number of ICU patients in your unit who receive renal replacement therapy, I think basically it will be between 10 to 15%. I think 10% is the low range. It's between 10 and 15%. Okay, so 75% of AKI patients in the ICU and 10% of ICU patients receive renal replacement therapy in the ICU. So basically, the point I want to make here is like AKI and renal replacement therapy. It's an everyday problem or issue or task for us intensivists in the ICU. So we're going to see everything regarding renal replacement therapy. So let's start with the catheter, because I think the catheter dysfunction is the most frequent causes of alarm on the renal replacement therapy machines. If you cannot provide renal replacement therapy correctly, if your machine keeps alarming, in most of the cases, this is due to your a problem with your catheter. So you have to know how to manage correctly your dialysis catheters. Indeed, if you are good with your dialysis catheter management, then you can really provide a good, stable CRT session, and it's going to be a really continuous CRT session. Because I know a lot of people who tell me, yes, we have CRT in our unit. We have continuous renal replacement therapy. But if every 5-6 hours there is a problem, the machine stops, you have you have to change your catheter, there is clotting and everything, it's not really continuous, right? Because you stop all the time and you ask your fellow to change the catheter, and that's not continuous. If you manage correctly your dialysis catheter, then you can provide really stable and really continuous CRT. The first thing you have to know when it comes to the renal replacement therapy catheters, it's that the Poiseuille law, right? What does it say? It says that the blood flow, the QB, the blood flow allowed inside the catheter. The blood flow is directly function of the diameter of the catheter. Okay, the more the size, the diameter is increased, the more the blood flow can be high. And the number 4 here, 4 is very important. It means that if you increase a little bit your dialysis catheter, for example, from 12 French to 13 French. Okay, I increase a little bit my dialysis catheter. Actually, I'm going to increase a lot the blood flow allowed inside the catheter. That's very important. And it's really inversely proportional to the length of the catheter, which means that if you have a long catheter, like for example 25 centimeters, then your blood flow will not be possible to be very high. Okay? That's very important. The Poiseuille law is extremely important. The second thing for the catheter, which is very important, is you have to place the tip of the catheter in a high blood flow rate location where the blood is circulating fast with a high blood flow rate. Where you can find this? The best place is at the entrance of the right atrium, at the entrance of the heart. And to reach this place, you have to decide to place your catheter in the right internal jugular vein. That's your first choice. And that's not just my idea. It's the recommendation from the KDIGO guidelines. This is the international recommendation. So when you decide where to place the catheter, it's not random. You have to decide to place the catheter in the right jugular vein for the first choice. And 15 centimeters because you're going to reach the entrance of the right atrium. Then if it's not possible because the site is occupied by, for example, a central venous line and you don't want to change the site of the central venous line, or if there is a clot of this internal jugular vein, then you go to the femoral vein. And then you place a 25 centimeter in the femoral vein. I still see somewhere, so in some places, too short femoral catheters. If you place your catheter in the femoral site, it has to be long enough to reach the inferior vena cava. So to get a high blood flow rate around the catheter. So to do this, you need a 25 centimeter of your dialysis catheter. And then if it's not possible, because let's imagine the femoral sites are dirty, full of fungus, for example, patient is obese, it's difficult, then you go to the left internal jugular vein with 20 centimeters. You never want to place a dialysis catheter in a subclavian vein. This has to be very exceptional. I actually only had to do it one time in my life. In 20 years of my career, I had to place a subclavian catheter only one time. So you see, right internal jugular vein first, femoral vein, and then left internal jugular vein. This comes from studies, of course. It comes from randomized controlled studies showing that you have more catheter dysfunction in the left jugular vein, in the left internal jugular vein than in the right internal jugular vein, right? So that's why you start with the right side and then you go to femoral side and then to left internal jugular side. What about the diameter of the catheter? 12 French, 13 French, 14 French, 15 French. You decide based on the blood flow you need, because we have just seen that if the diameter of the catheter increases, then your blood flow can be increased proportionally. So that's why if you have CVVHD in your unit, then you don't need necessarily a large catheter, because you can use a very low blood flow rate around 100, 120 milliliters per minute. But if you need intermittent hemodialysis in your unit, then you need 13, 14 French. Okay? And if you provide CO2 removal, ECOR in your unit, you need a blood flow rate of 400 to 450 milliliters per minute. So then you need a large catheter, 14 to 16 French. Okay? So the diameter depends on your renal placement modality you're going to use in your unit. Dialysis catheter recirculation, very important. What is it? Right? It's, here you have the blue arrows here show that you are in a site with a high blood flow rate location. So it's good. And then your blood is going inside the proximal hole, then get cleaned in the machine, go back, and then exit at the distal hole. But a little bit of blood, like 4%, 5%, goes again inside the dialysis catheter, the proximal hole, to get dialyzed the second time. You don't want this, because you lose some efficacy of your renal placement therapy session. So to avoid recirculation, what do you have to do? You have to have this distance of 2 to 3 centimeters between your proximal hole and your distal hole. You have to be in a high blood flow rate location, because when the blood exits here, if you are in a high blood flow rate location, you can understand that this blood in red is pushed away due to this high blood flow rate around outside the catheter, right? You understand? So that's why you want to be in a high blood flow rate location also. And you should never, of course, switch the lines, right? You never do this in Greece, I'm sure. In France, sometimes the nurses and the fellows and sometimes the doctors, they don't want to switch the catheter, so they switch the lines. That's not good at all, because here the blood gets inside by this hole and exits here. So you understand, if the blood exits in this hole, then you are going to have 40%, 50% of recirculation, which is actually not good at all. Your session is not efficient at all in this situation. So you do not want to switch the lines. Inside the catheter, you want a laminar flux. You don't want a turbulent flux, because turbulent flux means thrombosis. And you don't want thrombosis, because then your catheter is going to be clot. So to avoid clots, you need to have the design of your internal lumen, this one, that cycle C or kidney-shaped catheter. I would like you to know the type of catheter you have in your unit. I think it's very important for the correct management of a dialysis catheter. So this design is good. This is a cycle C or the kidney shape. You don't want these designs because you can see angles here. Angles mean turbulent flux, means clots. Same for the design of the tip of the catheter. You can see here you have lateral holes. Lateral holes not good at all because a lot of turbulent flux. And so you have a lot of clots in these lateral holes. Actually, when you remove these catheters, you can see very well that the holes are really clotted. So the recommended catheter is this one. The shotgun catheter is actually the one recommended. So the summary for the catheter, the diameter according to the modality, from 12 to 16 French, a cycle C catheter for the shape of the internal lumen, the shotgun tip catheter, go to the right jugular vein or femoral vein. You avoid the left jugular vein and the subclavian sites, of course. No line reversal. You place the catheter with the ultrasound guidance. You use biocompatible material, but in 2025, this is usually the case. You check the correct position with chest radiography when you are in the superior vena cava territory, and you remove your catheter as soon as possible. And when the patient goes to a surgery, or when you stop between two stations, it's important to use locking solution, and my preference goes with citrate. Timing of renal replacement therapy. Of course, urgent indication. There is a scientific consensus, no debate. All the experts agree that when renal replacement therapy, it's urgent in the situation of severe hyperkalemia, uncontrolled severe metabolic acidosis, uremic encephalopathy, and severe hyperhydration, like when you have pulmonary edema refractory to diuretics, and when you have severe dysnatremia. In this situation, there is no question, no debate. Everybody agrees that you need to start immediately a renal replacement therapy session. Otherwise, your patient is really at risk of dying, and that's not what you want, of course. When it's not urgent, let's imagine the creatinine is increasing a little bit every day. You have an AKI, and you don't know if you need to start or if you need to wait. That's a lot of cases in the ICU, right? We've seen 75% of our patients, they have AKI. So, the morning when you visit all the patients, sometimes you discuss with your colleagues, and you have these two approaches. A waiting approach, okay, let's wait for tomorrow. Let's wait for the day after tomorrow. Or some of our colleagues, they have an aggressive approach. They want to start early. And actually, in the past, I was like this. I wanted to dialyze very early. Now I wait a little bit more, I have to admit. But you still have these two approaches. And there's no right and wrong here. If you believe you are a waiting approach intensivist, it's okay. If you believe you are quite aggressive with renal replacement therapy, it's also okay, because there is no consensus. Actually, in 2025, we still do not have the right answer to decide when to start renal replacement therapy, because it's very complicated. And let me explain why it's complicated. First of all, there is no room for mistake. If you are a waiting person, okay, I want to wait. Just try to remember in your past few years, how many patients you have waited very long. Okay, let's see tomorrow. But finally, you decided to initiate renal replacement therapy. So let's imagine you have waited for 3 days, and then finally you start. Maybe these 3 days, it was not so good to wait, right? Because all the toxic waste and all of this in the blood, not so good, of course. And we know that if we wait too much like this, and then we finally need to wait to start, these have deleterious consequences. That comes from Akiki. I will show you here. Look, okay, patient who had early, this is from the Akiki trial, the mortality rate. If I start early, in the early group, 48% mortality. In the delayed group, in the delayed group, a lot of people, they finally did not receive replacement therapy. That was good, 37% mortality rate. But in the delayed group, if you finally need replacement therapy, then the mortality rate is even higher, 61%. That means that, okay, I don't know if I will need replacement therapy. I bet, it's like gambling. Unfortunately, that's like this. I bet this patient won't need. Okay, so I wait. But if I make a mistake and finally I need replacement therapy, then the mortality rate is 61%, right? So there's no room for mistake. That's what I want to say here. In the other hand, if you are too aggressive, right? And I'm sure I was like this. I'm sure in many patients I initiated in the past replacement therapy. And maybe these patients actually did not need it. Is it deleterious? Yes, it is also. It is deleterious. It is demonstrated that if you give replacement therapy to a patient who does not need replacement therapy, it's deleterious. Didier Payen showed that 15 years ago already. So whatever your strategy is, you have negative impacts on patient outcomes if you make the mistake. That's why it's difficult. Okay, I want also to tell you that it's difficult to choose because, of course, you have positive effects of replacement therapy. You are going to better control electrolytes, to better control the metabolic homeostasis. You can prevent it's easier to prevent fluid overload. You can avoid uremic emergencies if you start early. And if you do not start, if you start also, but you have some negative effects to start replacement therapy. You will have to deal with anticoagulation and maybe complications of anticoagulation. You may have to deal with the catheter complications. You may lose in the circuit some drugs and nutrients. It's also more work for your team, more expensive, and your patient cannot move that much when you have replacement therapy. You see, so you have pros and cons to start replacement therapy. And it's not easy every day at the bedside, of course. And I can also tell you that in 2025, you cannot know. When you're here, serum creatinine rise, and I'm here, I don't know which direction. Everything is possible. That's why it's difficult. And so can you get some help from the guidelines? Not really. This is the KDIGO guidelines. This is quite old, but I can tell you there will be new KDIGO guidelines next year. So maybe it will be more information about timing. But for now, the KDIGO, the international recommendation, they don't help very much. And the other societies like ATS and the French society, they don't help very much when it comes to timing. And when you look at the practice in the world, it's very different. In Greece, for example, I'm sure it's different than in France. In the north of Greece, it's probably different than in the south of Greece. Even in your unit, in your team, within your team, you have doctors that will start early, and maybe you have other doctors that will start a little bit later. The practice is very different. These are the studies, but these studies, right? They have quite a few years ago, AKI, ideal ICU, start AKI. The three on the right, they did not show any difference between the early group and the late group. But the A-lane, right? The A-lane group, the German study, the monocentric German study, found a difference in favor of the early group. Do you know why? Do you know why the German study here, we have a better outcome when we start early, and in the other 3 studies, no difference when you compare the early and the late group? I think the difference is because it was cardiac surgery in the ALN trial. And a lot of patients, they had fluid overload. Actually, I looked, 75% in that of patients in this study, they had fluid overload. So in my practice, when a patient has fluid overload, 10 kilos of fluid overload, then in my mind, it's a criteria that telling me, okay, I think we need to start a little bit earlier. I'm not going to wait the same time if I have a patient with no fluid overload or if I have a patient with fluid overload. Because fluid overload, we know it's extremely deleterious. Fluid overload is very deleterious from all organs. So if I have a patient with fluid overload, I will tend to start a little bit earlier. That's my practice. Shall we wait more? Because that's the result of the AKK trial number 2. These investigators, they randomized again patients. They took the late group of the AKK trial, and they said it's going to be the early group in the AKK 2 trial. Okay, and then they wanted to look at another group, delayed, very, very delayed. Right? If serum urea concentration reaches 50 millimole per liter, that's very, very late. They were waiting for the complication. I wouldn't want to be a patient in that study. I wouldn't like to be in the delayed strategy, to wait until you reach the complication, metabolic complication. Not good. And of course, in that study, the mortality was higher in the delayed strategy. So you can wait a little bit more in 2025 based on the result of AKK, based on the result of IDEAL, and start AKIs. But you don't want to wait too much because the AKK 2 trial tells you that then you have deleterious consequences to your patient. So to summarize the timing, consensus on urgent indications, still no clear consensus when no urgent criteria. Literature is more and more in favor of the waiting strategy, but not too long. That's very important. Except in case of presence of fluid overload, I'm starting a little bit earlier. I hope I gave you clear messages on the timing. Let's talk a little bit about the dose of renal replacement therapy. Well, here the clinical guidelines are very clear. They recommend to deliver an effluent volume of 20 to 25 ml per kilo per hour of CRT in AKI. This is a 1A recommendation. 1A, it means it's a very strong recommendation. Why? Because it comes from 2 New England Journal of Medicine studies from the US and from Rinaldo Bellomo in Australia, 2008, 2009. Very clear, showing no difference between intensive therapy and less intensive. And so the dose is here, the dose of 20 to 25 here in this recommendation are based on these 2 trials. What is extremely important to understand regarding the dose is when you talk about the dose, you have to place a word in front of the dose. Are you talking about the prescription, or are you talking about the dose really administered to your patient? Because it's totally different. If I prescribe 35 ml per kilo per hour, that's my prescription in the morning. Okay, I'm going to lose a little bit of dose because of the nursing time. Because when my nurses, they do the nursing, they stop the exchanges, they stop the therapy. They do not stop the blood flow pump, of course, but they put that's the safety mode. I hope you know what the safety mode during nursing. I think it's very important to use it. Now on the new machines, you have the safety mode. You have only the blood pump running, but not the, the effluent pump, for example. So I'm losing a little bit of dose. During every change of the bags, I'm losing a little bit of dose. If I have surgery, my patient goes to the operating room, I'm going to lose a little bit of dose. CT scan, if I start a new session. If I have a catheter problem, look, I will lose some dose, right? If there is thrombosis. So if I prescribe 35, I'm going to get 25 ml per kilo per hour to my patient. I administer dose 25. That's what I want. So if I want 25 to be administered, I need to prescribe 35. So please, when you use the word dose of replacement therapy, put an adjective in front of it. Administered versus prescription. Very important. That's the summary. Administered dose, 25 ml per kilo per hour. Prescription, 30 to 35 ml per kilo per hour. What about the modality? Well, first of all, when we talk about the modality, it's very important to use the correct abbreviations. And I can hear so many mistakes, even in my hospital. Sometimes they use CVVH. They use the word CVVH for CRT. In my unit, we do a lot of CVVHD, continuous veno-venous hemodialysis. But some, especially the experienced doctors, in the past, they were doing a lot of CVVH. Now they do CVVHD. And so they use the word CVVH for CRT. No. So please use the correct abbreviations when you talk. And I think it's also very important for the young doctors, the fellows, the young nurses. They want to hear the correct abbreviations. Otherwise, they won't understand anything. And they wouldn't dare to ask why you are talking about CVVH when your therapy is CVVHD. So I think please use the correct abbreviation. Of course, you have diffusion for dialysis, and you have convection for hemofiltration, and you have different debates when it comes to the modality of replacement therapy. First of all, you have intermittent hemodialysis versus CRT. I don't know in Greece if you have a lot of intermittent hemodialysis in the ICU, but in France, 75% of the intensive care units in France, we have both therapies, intermittent hemodialysis and CRT. So we usually start, that's my practice, when the patient is very sick at the beginning, I initiate CRT, and when the patient gets better, I'm using intermittent hemodialysis to favor mobilization and everything. But you can find doctors who want to start with intermittent hemodialysis at the very beginning when the patient is very sick. I don't think it's good practice, but you can still find this. And it's a big debate. It's a 25-year controversy, a lot of debates in the literature and in the meetings. You have advantages of intermittent hemodialysis, of course. It avoids the risk of anticoagulation because you can provide intermittent hemodialysis without any anticoagulation. It's easily deployed at the bedside. I put parentheses here because it's also the case with CRT. It allows the patient to achieve greater mobility, of course, because between the sessions, you can mobilize the patient. It's a little bit cheaper per se. But the advantages of CRT, you provide greater hemodynamic stability, better control of the volume status, better control of the electrolyte and acid base, better control of the temperature. It avoids, and I think it's very important for the hemodynamics, the solute swings, and actually it's for cerebral edema, it's mandatory to use CRT. And it provides a better uremic control. When it comes to the clinical guidelines, as you can see, that you want to use intermittent hemodialysis and CRT as complementary therapies. And I think it's a very important word here. That's what I was explaining before. Start with CRT and then use intermittent hemodialysis when the patient gets better. I think that's complementary in this situation. When it comes to mortality, we will not find any difference. But like many things in the ICU, right? No difference in terms of mortality. when the first session is intermittent hemodialysis or CRT. But when it comes to renal recovery after your AKI episode, is the patient is going to recover? You can get this patient dialysis independent. You can wean, you can stop the dialysis. Well, if you have started with CRT, then this is associated with a better renal recovery. That was found in Sweden, that was found in Canada, same result. We found the same thing with my fellow Martin Bonacieux, with a large 1 million ICU patient over 4 years. We found this association. CRT is associated with better renal recovery than with intermittent hemodialysis. And it's not difficult to understand why. If you provide CRT, you have better hemodynamic stability, you have less second hit of your blood pressure decreased, and so it's better tolerated, so you have less second hit on the kidney who is already very sick, right? So I think with CRT, you have better renal recovery. So actually, intermittent and CRT, I don't think there is a debate anymore, right? It should be complementary approach. You should start with CRT when the patient is sick, and then you go with intermittent hemodialysis when the patient gets better. And now CVHD or CVH or CVHDF? Which modality for CRT? Diffusion, convection, or a little bit of both? A little bit literature. This is really a topic where the literature is very poor. Actually, there is a very small study here from 20 years ago showing that, you have a little bit of more, the circuit you can get the circuit a little bit longer with CVHD. Otherwise, there's not so much difference in terms of solid clearances. We did a survey recently published from 74 countries that was published in Journal of Critical Care this year. This is from 2025. And actually, in the world, CVHDF is still the most prescribed modality in front of CVHD. In gray, this is CVHD, and in orange is CVVH. So CVHDF is still the most prescribed in the world. But what you can see is you have a lot of heterogeneity of practice. When it comes to the ratio convection to diffusion in CVHDF, you can find everything based on this survey. And if you use CVVH, the pre-post is also very, very variable. A lot of heterogeneity of practice. Because this is easy to understand. There is not a huge, strong recommendation how to use this modality of CRT. Okay? So I don't know in Greece what's the most frequent CRT modality, if it's CVVHDF or it's CVVH or CVVHD. But you can, there is no paper showing that one modality is better than the other. I think it's totally safe to use one of these in your unit. I think you have to use the modality you know the best. What the guidelines tell you, nothing on CVHD versus CVH versus CVHDF. So the summary for the modality, the use of CRT as the initial modality of in the ICU seems to be associated with better renal recovery after severe AKI, potentially due to better hemodynamic stability during CRT. CVHD, I think there is an advantage. What I like with CVHD is you can decrease your blood flow. And that can be interesting if you use citrate anticoagulation because you don't give too much citrate. So that's why I like CVHD. CVH you can use, of course, but please, if you use CVVH, those of you who use CVH, please calculate the filtration fraction at the beginning when you do the prescription. And CVHDF could be an interesting compromise. For the next 10 minutes, I'm going to talk about citrate anticoagulation. What is the mechanism of action of citrate anticoagulation? Well, citrate is going to bind ionized calcium. and you're going to make calcium citrate complexes. And if you bind the calcium here, then coagulation will not be possible because calcium is necessary at all the steps of the coagulation cascade, right? So that's how citrate works. It binds the calcium, so you have no calcium anymore, so it cannot coagulate with no calcium. Then you bind the calcium and you have this calcium citrate complex. It's interesting to look here at the calcium citrate complex. 2 positive charge binding the 2 negative charge here of the citrate molecule. But you still have 1 carboxylate radical here, free. This free radical carboxylate unbound provides an acidic effect. So if you have calcium citrate complexes, they tend to make your blood more acidic, acidification of the blood, okay? When calcium citrate complexes accumulate, it tends to acidosis. That's the message here I want to provide. Something very important here. If you use heparin in your unit, okay, I use a little bit of heparin. I'm going to anticoagulate a little bit. I use a lot of heparin. I'm going to anticoagulate a lot. This is almost a direct, like a linear association. With citrate, it's totally different. It doesn't work like this. If you are scared of using citrate, and you cannot say, okay, I'm going to use just a little bit of citrate. That's not going to work like this because you are going to decrease a little bit your ionized calcium here, but your bleeding time will not increase. The message here is if I want to use citrate, I do it 100%. I do it correctly. I cannot be a little bit scary with citrate. If you ask a little bit scary, don't do it. Okay? The message here is if I want to use citrate, I really do it. What happened to the calcium citrate complexes once they are made? I want to spend 1 or 2 minutes here because a lot of people do not understand. If I start here, let's imagine, so this is CVVHD, right? I give a little bit of citrate here. Okay. I have calcium citrate complexes in the blood. I have ionized calcium here. Okay. And then it goes to the filter. And then they face diazate. So do I have ionized calcium in the diazate? No, I don't have. My calcium concentration is 0. So I have a little bit of calcium, ionized calcium, going to the effluent. Do I have calcium citrate complexes in the effluent? No, I don't have. So I have a little bit of calcium citrate complexes going to the effluent to be removed. Not a little bit, actually, 50%. 50% of my calcium citrate complexes are removed by the effluent. So I'm losing a lot of calcium in the effluent, right? In the diazate, I'm losing a lot of calcium. The ionized calcium plus the calcium from the calcium citrate complexes. And what a lot of people do not understand is the calcium you give here is only the calcium. Interesting, because it's only the calcium that you give to replace what you have lost in the effluent, nothing else. That's why the 2 pumps, the diazate pump, the effluent pump, is working with the calcium pump here. Okay? If I increase my diazate flow rate, if I increase my effluent flow rate, then automatically my calcium pump is going to be increased by the machine. Because the calcium here, again, is only here to replace what I have lost in the effluent. I think it's very important to understand this. What are the 3 main advantages of citrate anticoagulation over heparin? I think it's clearly demonstrated that citrate provides a better, longer filter lifespan, demonstrated in all the studies. This is very rare to have such a consensus in the ICU. All studies showing the same thing. the old studies, the recent studies, the large studies, the small studies, the monocentric studies, the multi-center randomized control trials showing exactly the same thing. Why? I don't have to say anything. Look at the pictures, right? With heparin and with citrate. It's easy to understand why your filter lifespan is going to be increased by 2 times or 3 times. Of course, less hemorrhagic complications because you don't, it's a regional anticoagulation, so less bleeding demonstrated, okay? And that's the conclusion of the citrate, less hemorrhagic complications, longer filter lifespan, and less unwanted stops. You can, if your fellows, they are happy with citrate because they can sleep when they're on call. When I was a fellow, I was always managing the problems and the circuits because of heparin. Now my fellows, they sleep during the night shifts because they have citrate and everything is okay. Which is also good because you remember what we said in the introduction, you have this dialysis dose that will be optimized because you have less unwanted stops thanks to the citrate anticoagulation. If you want to manage correctly the complication, because with heparin we have the bleeding complications, with citrate you have the metabolic complications, 2 complications, accumulation and citrate overload. 2 complications. Please do not use intoxication. Intoxication doesn't mean anything, and you will get a lot of confusion when you talk to your colleagues if you use intoxication. Accumulation, overload are the 2 correct words, I believe. You have a benign complication. This is metabolic alkalosis. This is citrate overload. There is correct metabolism of your calcium citrate complexes. No problem. Not dangerous, okay? But you have the dangerous complications. It's when you have no metabolization of your calcium citrate complexes because your Krebs cycle, which is also called the citrate cycle, does not work. And in this situation, you have an increase of your total calcium over ionized calcium. It's increasing, more than 2.5 or sometimes more than 2.3. I think that we should not choose a threshold. When you have the total calcium over the ionized calcium, which is increasing, you are accumulating calcium citrate complexes. You have metabolic acidosis here. And it's also a situation when you always have to increase your calcium substitution. So each time you get a surveillance measurement and you need to increase your calcium substitution, please pay attention. Maybe you are accumulating your calcium citrate complexes. The good news is when you have these complications, what you have to do as a doctor is the same. You can decrease your blood flow or you can increase your diazide flow rate or your effluent flow rate or your ultrafiltration flow rate if it's convection, if you use CVVH. Very important to know how to manage these 2 complications. So summary for anticoagulation, less hemorrhagic complications with citrate, longer filter lifespan, less unwanted stops, so better optimization of your administered dialysis dose. Be aware of potential metabolic complication. We have seen these 2 complications, citrate overload, calcium citrate complexes accumulation, and I didn't have time to show you, but the best predictor of calcium citrate complexes accumulation is your lactate and the lactate level and actually the lactate kinetics. If in your unit you have a lactate increasing, that means your patient is very much at risk of accumulation of your calcium citrate complexes. So the conclusion, I think it's just 45 minutes. If you want to provide to a patient a continuous, safe, and efficient CRT session, all aspects of the CRT prescription should be masterized. Timing, dose, modality, anticoagulation catheter. You have to masterize everything. You cannot be good at 4 out of these 5 parameters. You have to be good in the 5 parameters. But also do not forget how to win renal replacement therapy. I didn't have time to talk about this. And also the membrane is also very important. The characteristics of the membrane are also very important. With that, I would like to thank you very much for your attention.
Thank you very much, Thomas, for this very insightful presentation. You have given a lot of material to reflect on regarding the current state and the current practice of renal support in the ICU. And now we have time for questions. I would like to say that this lecture is some kind of a recap for our presentation that we performed during the last academic years. We have here in Greece, Thomas, a small but very dedicated and well-organized group interested in acute kidney injury, and we are very tight-knit, and it was very nice to hear you, to have you with us in this evening. And now we will start with our question. The first one is on the use of biomarkers. Can we use any biomarker to start or stop RRT? What are the data so far?
So yeah, that's a very good question. I think the biomarkers, we still need to continue to work on the biomarkers. We have more and more biomarkers arriving, proposed by the industry, proposed to help us to manage renal replacement therapy and to optimize the management of these AKI patients. To start renal replacement therapy, at this time there is a biomarker which is under assessment. It's the NephroClear. I don't know if you heard about this one. The NephroClear biomarker, when it's when it's very high, it may tend to tell you that the patient is not going to escape from renal replacement therapy. Sometimes you see, okay, my serum creatinine is rising. I'm not sure if the patient is going to need renal replacement therapy or not. But if we can find a biomarker telling you, okay, this patient is going to need renal replacement therapy, then I think it will be a good improvement. And the NephroClear, I think you can look for this. It's proposed by the company bioMérieux. NephroClear could be interesting. For the weaning of renal replacement therapy, we can also find some biomarkers, but at this time in 2025, they are still not very performant, not very powerful. So I cannot recommend anything for the weaning. Maybe you can use the furosemide stress test. That's the one that is also provides good performance in the literature. If you don't know if the patient is going to be able to continue without renal replacement therapy, you can see if there is urine provided with the furosemide stress test. But what I do when my patient is under CRT, I'm waiting to see the urine. I'm waiting to see the urine before I stop CRT. If I see urine in the bag, then I'm happy and say, oh, okay, my patient starts to make urine. I will be able to stop CRT maybe very soon. So if my patient doesn't have any diuretics, I have to wait 500 ml per day to say, okay, I'm safe to stop CRT. If my patient is under diuretics, it's more than that, maybe 2 liters. And then I can win. But before I stop, I ask question. My patient, does he have fluid overload? If still a lot of fluid overload, I think it's not a problem to keep it for an additional day just to remove, because it's easier to remove fluid with CRT rather than with intermittent hemodialysis.
Thank you, Thomas. And the next question interfere with the previous. And Vasiliki Koutsoukou from Athens, she asked you that there is notion that giving diuretics during CRRT helps the kidney to maintain or regain their function. Could you comment on this?
No. I'm using diuretics only when I need. I think this is less true than before, but in the past, too many intensivists were using diuretics for everything. Now I think it's less true. People became more reasonable because we improved and the recommendations are quite clear when it comes to the diuretics. I think there is only one indication of diuretics in the ICU. One indication, which is fluid overload. Okay, my patient has a fluid overload. I told you this patient has fluid overload. Okay, it's associated with bad outcomes. I don't want fluid overload. So if I can use the diuretics to get rid of my fluid overload, that's okay. But to provide diuretics just to get urine, then your nurse is going to be happy because she's not going to call you because the patient did not urine very much. That's not a good practice in my opinion. Not all the patients in the ICU should receive diuretics. I remember when I was a fellow, all the patients, they had protocols based on the urine output, and then if the urine output is very low, then provide diuretics. I don't think this is good practice. Diuretics means you want to remove fluids due to fluid overload. And I don't mix, that's my practice, I don't mix diuretics and renal replacement therapy because then I don't know what's going on. I don't know, if I want to remove fluid, I have a machine, then I increase my net ultrafiltration. I increase the removal of fluid with the machine. I'm not using diuretics. Okay?
Okay, thank you. The next question is from Northern Greece, from Christina Theocharidou. She's from my hospital, from Papanikolaou Hospital. When using CRRT, apart from citrate in catheter lock or heparin lock, what do you think about locking the catheter with normal saline solution?
I have a clear answer for that. When it comes to the catheter locks, several randomized control studies have been done. Everything that compared saline to heparin or saline to citrate, you have more catheter dysfunction in the saline group. So I don't think you should use a catheter lock with saline. And now the catheter locks are not expensive at all. So you have no reason not to use a catheter lock with heparin or with citrate. If you use saline, you have to change your practice for a catheter lock with heparin or citrate. And then the comparison between citrate or heparin, there is one study comparing, and there is no difference. But I think it's just because the duration for which the patient they had the catheter was short, and they did not have time to show the better performance with citrate. So I use citrate lock, and I'm very happy to have the possibility to use citrate lock. I have shown you how citrate is a good anticoagulant. You saw the pictures, so I really recommend to use locking solution with citrate.
Okay, thank you, Thomas. And maybe the last question from Athens also. Could a 24-hour measured creatinine clearance help us decide when to start CRRT, at what threshold? And I have made a remark on this. I would like to make a remark because recently I have read in the literature that new techniques are available now, continuous real-time online GFR monitoring, and this technique was recently approved by FDA. What is your opinion on this approach?
I believe that the initiation of renal replacement therapy at this time in 2025 is not based on a number, which could be, the number of urine that the patient is making, the serum creatinine, the creatinine clearance. The creatinine clearance, I like the creatinine clearance. You can get the right number when you get the urine output, and then you met. This is the best way to monitor your kidney function. But these numbers are not the ones who are telling you to start or not start renal replacement therapy. To start or not start the renal replacement therapy, it's the whole thing. It's the patient, is what my patient has, the evolution during the previous few days, what are the cardiac function, what can the patient tolerate the fluid overload. All of this is the clinical thing, but it's not a number. It's not a KDIGO classification. It's not this, right? It's not. Of course, if you have complication, hyperkalemia, blah blah, yes, no problem. But then it's your clinical perspective with this, and I'm not relying on numbers, creatinine or creatinine clearance and stuff like this at this time in 2025.
Okay, thank you, Thomas. I think that there is time to close our discussion. Thank you very much. Thank you to everyone for all your thoughtful questions. Thank you, Thomas, for a powerful and thought-provoking lecture. And I would like to wish to everyone good summer, and to you. Thank you, Thomas. It was very nice presentation.
Bye, my colleagues from Greece. Bye-bye. Take care.
Bye. Bye to everyone. Thank you.